Yang apa? Yang bawasan Levian. Itu bawasan Levian.
Dia bukan bawa apa-apa pun dia tak nak pergi. Macam mana dia boleh dapat kontak dia tak tahu. Ada orang macam mungkin boleh tak. Saya nak apa nak kontak ada orang kita.
Especially topik dia yang dia DTI assessment dengan causes of high LV activity.
Dia kalau boleh. Tak boleh.
Okay, good morning everyone. Again, I'm going to be presenting a topic on circulatory shock. Initially, this was planned to be a case-based presentation. Unfortunately, I don't remember the case, so I can't really present the case. So I converted it into a full-on circulatory shock presentation. Sebab I can't really remember
the case.
Kind of we discussed the case yang trigger this presentation, but I think which patient.
Case yang kita tengok tu kan shock tu.
Shock, but I don't have the S number, I don't have the name, so I just speak English.
Banyak je patient yang shock ni tak apa.
But in many cases, this will be a general short presentation rather than focus on LV. Okay, so I'm going disclaimers first. I have a very pragmatic approach to ultrasound, as in as a tool, it's useful, but if you have some other constraints in order to perform ultrasound, and then there's other management priorities on the floor, it's not something that I focus on. I think in most situations you can get away with physical examinations. With that said, I'm also not.
Are you good enough? You should include the Dunning Kruger photograph.
But in any case, I'm not an expert on this topic. I'm a shock ultrasound, in general critical care. So even if you are capable of identifying pathology, delineating pathology, it's not necessarily the solution to all your answers, because sometimes things are just simply overcomplicated beyond what you and your colleague might be able to handle. And then lastly, this is not something that you can apply to as a broad stroke. You can apply this presentation to different populations, meaning geriatric, pediatrics, and pregnant patients. I also will not be touching much on sepsis, because sepsis and the related biomarkers, I think, deserves a topic on its own. Kalau I include it here, it's going to be 4 hours, 3 hours before we can even settle to sepsis 3.0. By the way, what's our stance on sepsis 3.0 at set time? What's the stance of our emergency department regarding sepsis 3.0?
Kita kena tanya. Actually, depends on the situation, depends on the patient. Apa lah, continue.
Okay, so we're gonna elaborate first on key concepts before we get into the ultrasound presentation. So why is shock important? Charlie, why is shock important?
Depending on also on patients in terms of oxygen wise, and then the heart rate, cardiac output. So it means
so there's this subject in medical school called the common pathways of death, and there's three typical entities yang usually group and bundled together. The number one is shock, number two is bradycardia, and number three is AKI. So all of these three components usually have strong intercorrelation with each other, and shock is really common pathways of death. inability to identify shock at early stages means that you risk missing that window of intervention and you might allow the patient to decompensate. So it's important to know shock because this is what, in most cases, early identification, categorization is what's going to assist you in determining what kind of treatment that the patient will receive. So the indications of shock that we have, clinical measurements, history taking and whatnot, are not actually truly representative of shock. If you read into pathology textbooks, shock is about derangements on the cellular level, and we don't really have a good testing capability to determine whether or not tissues are receiving the adequate perfusion. There's focuses on lactate, there's other biomarkers in the literature, but either they don't really help you to narrow down truly the etiologies of shock, or they are impractical, as in most of the time it's expensive. So what we look instead are markers that may indicate that the patient has shock on the tissue level. So this would be your typical HLP, patient that will complain of blood loss, patient that will complain of chest pain, patient that will complain of syncope, patient that will complain of palpitations. You complement it with your physical exam, CPTVR, whether or not patient had evidence of external blood loss, whether or not there is GDP elevation. You complement it with your monitoring data. Your for our clinical practice, that will be the MAP. I'll go into that later. And you make and you see your biomarkers, investigation and whatnot, and you try to create an what do you call it? An ideal clinical picture that encompasses all the data that you have in a coherent and plausible manner. So one of the problems that I see during MOs tend to suffer from in red zone is that they tend to approach different shock classes as in their same entity. You see quite frequently patients at that time because of trauma or the bleeding are on noradrenaline or any other crisis, and it shows that you don't really understand the mechanism of shock that's going on in that patient. Okay, so the aims of shock assessment, as I said before, you want to identify it early. You want to determine what's the etiology of the shock. You want to administer the appropriate intervention. You want to determine whether or not there's any other paraphenomena, superimposed shock, acute or chronic phenomena, ataupun overlaps of shock syndrome, which is quite common especially in patients with uncontrolled chronic illnesses. And then you want to see whether or not your patient has responded to your interventions. Okay. So the right side definition of clinical shock is hinged upon mostly blood pressure dengan perfusion markers. Clinical hyperperfusion, we've gone through this before yesterday, 2 days ago, when we had that dengue mortality. Whenever you have BP yang shows the patient in shock, but your clinical assessment is contrary to what the BP is telling you, you need to keep in mind that your monitors have limitations, and knowing the limitations of your monitor will help you to defend yourself, as in justifying why you did for that patient what you did. Okay. Another important definition of shock is when you have a patient who's admitted, you have a baseline BP, and then I'm going to touch on it later.
Oh, I did. Okay.
Okay. So another definition that you can use is a patient who's been admitted. We have a trend of normal readings, and suddenly patient has a drop in your BP, but still within normal range, more than a factor of 20 to 25%. So we know that patients punya compensated BP, and now there's a reduction without any apparent explanation. That should prompt you to consider that the patient has a shock going on. Another one is high shock index. So high shock index has to be interpreted in a very contextual manner. You can't apply the same shock index in your cutoff point for different populations. Pregnant patients have different pathological shock index. Young children, pediatric patients have different cutoff for shock index. Elderly patients, especially those who are on multiple medications, polypharmacy, have a different consideration in the shock index. But when you have a sustained elevation in shock index, that again complements with your history and physical findings, then you need to consider it as shock as well. And then lastly, you have your elevated biochemical markers, your end organ damage, AKI, liver injury with bilirubin elevation and whatnot. So this is a fairly simplified presentation of shock beyond what you are taught in medical school. So back in medical school, pretty much they stop. Where's my mouse? Anyway, so they pretty much stop at the first group. There's hypovolemic, there's distributed, there's cardiogenic, obstructive. And then when you go into clinical practice and you have to make decisions on your own, you realize that these broad classifications are not that helpful. There's a strong difference between hemorrhagic hypovolemic shock and a simple hypovolemic shock. Similarly, patient who has hypovolemia but one is state spacing, the other is not, may have high incidence of superimposed tamponades. And in distributive shock, it's not just about static shock. You sometimes have to deal with neurogenic and anaphylactic shock. With cardiogenic shock, especially, it's very, very, very complicated. If your patient is suffering from a cardiogenic shock that is not due to acute coronary syndrome, oftentimes they are not going to get the intervention that they need, mostly due to cost-related reasons. Just to exemplify the problem, advanced heart failure is now being considered as a palliative disease if the patient could not afford the necessary mechanical circulatory support. The device that they need, which kita guna, is called HeartMate-3. It's an LVAD, and the cost of that device alone is 700,000. So unless someone's willing to splurge and help someone they don't know randomly, it's not likely that we're going to find solution to cardiogenic failure that is not due to any ischemic cost anytime soon. And then you have to remember that arrhythmogenic shocks are also a legitimate form of shock. Patient yang ada bradycardia, no matter what the BP, kalau they're not perfusing well, you have to treat it as if they're in a state of shock, because bradycardia has a much clearer linear relationship with cardiac output compared to tachycardia. There's a few phenomena in tachycardia before you get the compensated pathological tachycardia. And then you have other terms like forward and backwards failure. So SCAPE is a form of forward failure where you have an excessive high afterload in which the LV cannot compensate enough to overcome that afterload. Backwards failure is when you have a congestion. Basically, there's forward failure, and the blood that's being sent from the other side of circulation cannot be moved forward, and as a result, you develop congestion. So this is not a minor entity. Venous congestion is being emphasized more and more as a cause of hyperperfusion. Basically, if you have elevated pressure on the venous level, that's going to affect your perfusion pressure of your vital and organs, tissues. To elaborate further into cardiogenic shock, you may also have intracardiac shunt. This is frequently cited in literature as being as high as 1/3 of the patient, and most of the time we don't really check it. So the problem with intracardiac shunt is that if you put these kind of patients on a positive pressure ventilation, or they develop high intrathoracic pressure without positive pressure ventilation, it increases their shunt fraction, causes further mixing of oxygenated with deoxygenated blood. And again, because you can't classify, you can't really properly identify shock at the tissue level, you tend to miss it. And then you have obstructive shock. Obstructive shock is fairly simple. You have something that's impeding blood flow forwards, and so you don't get perfusion. The treatment for an obstructive shock is the relief, is that you need to release that obstruction. Most situations it's pretty simple. It's simple if tension pneumothorax, you insert a chest tube ataupun buat open thoracotomy. If it's cardiac tamponade, you have to drain the tamponade. Kalau patient ada, for example, what's a more complex cause of obstructive shock? ARDS is a form of complex obstructive shock where there's no immediate reversal that you can offer to the patient. The hypoxemia causes hypoxic pulmonary vasoconstriction, and that redistributes itself to the upper right ventricle and causes acute pulmonary hypertension. So the strategy is a bit different. So not all obstructive shock are simple, but the ones that you are required to know are fairly simple, whether or not you berani buat atau tak berani buat je. Another, I don't know if this is going to be significant or not. I've had encountered before massive right-sided pleural effusion causing obstructive shock. Basically, you have a lot of fluid in your pleural space to the point that it's causing pressure punya mass effect on your vena cava. Surgical drain that patient and suddenly dia dah tak taking, the BP dia dah okay, so something that to ponder about. And then lastly, you have iatrogenic shock. This is one of the most kind of shock. Huh?
Okay, you're talking like obstructive shock simple.
Mostly simple. They are complicated obstructive shock.
Okay, mostly, I mean mostly it's reversible, right? Okay, mostly, because mostly. Betul, last time saya satu lagi obstructive shock.
You're talking about LV upper tract obstruction. Aortic stenosis. Stenosis.
So, severe stenosis, nothing much can be done. You just need to freeze lah. But it's worth for you to know patient what kind of yang easily reversible. So iatrogenic.
So iatrogenic shock is when you want to pass over, suddenly the BP drops and you can't.
Tambah satu lagi, tak? Before iatrogenic. Mana aku mana? Apa ni? Okay, tak apa. Siapa nama? Sarah. Hai Sarah. Ini okay lah. Waktu you medical student, kita belajar yang this one. Okay, I pun baru tahu ni this one iatrogenic. Baru tahu hari ni. We learn. Okay, I pun also learn this something new. Okay, so we learn together. So tambah satu lagi. Apa lagi? Latest classification. Especially dalam pediatric. Tak ada dalam pediatric pun, semualah sebenarnya. Pediatric yang buat dulu. Hypovolemic, distributive, cardiogenic, obstructive. Okay, so kalau hypoxia, fall into what? Category. Severe anemia tapi intravascularly normal.
Metabolic shock.
Metabolic shock.
I know the term dysphoric shock exists, but usually it's grouped under septic punya shock kan.
Macam mana?
Dysphoric shock.
Okay, it's called dissociative shock. Okay, dissociative shock. Dissociative ni, okay, there is satu lagi dissociative. So the hypoxia and also severe anemia that causing, actually hypoxia, severe anemia kan dia boleh dapat features of cardiogenic. Okay, dia boleh dapat features of distributive. Okay, so sebab tu dia nama dia dissociative shock. And patient severe anemia, patient datang let's say lah drowning. Kan? Lepas tu macam mana patient yang drowning boleh dapat hypotension? Mestilah ada lah kan? Kan? Kenapa? Macam mana hypoxia itself causing shock?
Hypoxia, pulmonary vasoconstriction.
Okay, what else? So same goes to anemia lah. Same goes to anemia. The pathophysiology almost the same. Because of the poor oxygen delivery. So macam mana dia boleh dapat hypotension? Hypotension BP kan? MAP equivalent to cardiac output stand TPR kan?
Cardiac perfusion.
Okay, dia tak ada perfusion TPR. Okay, lepas tu tak ada perfusion. Lepas tu macam mana dia boleh dapat dia effect kat mana cardiac output? Dia effect ke TPR?
TPR dia effect right ventricular preload.
Preload? Preload is hypovolemic. Macam mana hypoxia and severe anemia? Siapa yang attend dengan I, yang patient severe anemia 1 point something yang collapse tu? Tak ada orang kat sini. Patient dapat satu patient okey je, initially okey lah, GCS full macam dia cakap. HB memang 1 point something tapi tak ada orang nak confuse. So patient tu stable. Ada dia sikit. Lepas tu terus collapse, CPR. During CPR kita transfuse, lepas tu okey. So macam mana severe anemia? Macam mana patient tu boleh dapat cardiac arrest? Pathophysiology.
Basically, my suspicion is that dia punya cardiac dengan brain is not getting the substrate it needs. So dia ada blood pressure dysregulation dengan arrhythmia. That's the typical fenomena kalau kita nak intubate patient dengan high shock index.
Okay, so again, hot killers. HOP. Hot killers stands for? Sebab benda tu yang kills the patients kan? So, apa dia hot killers? Hypotension, hypoxia, hypotension, oxygenation lah, hypoxia dengan severe metabolic acidosis. Hot killers adalah tambah lagi dia orang kata diamond apa semua, tapi for me it's jadi like hot killers. So benda tu macam mana hot killers tu boleh kill the patients? So basically it's a vicious cycle kan. Oxygen, start dengan oxygen dulu. So oxygen, okay, hypoxia, dia akan jadi reduced tissue perfusion, reduced tissue perfusion, dia akan jadi metabolic acidosis, metabolic acidosis akan jadi cerebral perfusion pressure. That's apa advance sangat ni? Kau ni memang advance. Okay, ni macam mana? Hypoxia, reduced tissue perfusion,
arrhythmia for the heart will be
reduce tissue perfusion. Bila reduce tissue perfusion, hypoxia to the tissue, okay, so dia akan jadi metabolic acidosis, and also the heart itself requires oxygen to have a good contractility, kan? Okay, so lepas tu SA note dia pun dia akan affected lah. So sebab tu dia akan maybe dia boleh dapat arrhythmia ataupun dia just terus dapat poor contractility, lepas tu terus stop. Okay, so because of oxygen itself, and then satu lagi metabolic lah, hypoxia, reduced perfusion, sama juga anemia. Anemia is oxygen, tak ada oxygen nak deliver sebab HB dia low sangat. Okay, so oxygen ada banyak tapi dia nak deliver to the tissue tu tak ada. It's the same goes, daripada physiology sama juga. Okay, so metabolic acidosis, myocardial depression, okay, so basically depression to the vital organ. Okay, so dia akan dapat shock. This is a vicious cycle. Okay, so it categories dalam one of the poor contractility. Okay, so kalau dalam cardiac output, so bila ada poor contractility, poor cardiac output, okay, poor cardiac output, samalah. So akan jadi hypotension. Okay, so it's called dissociative shock. So you tahu, you cari kalau let's say patient in shock, you tak tahu patient in shock apa ni, nak manage ni. Sebab management is different. Okay, so you tahu, cari yang paling senang lah. Reversible hypovolemic, okay, tak ada. Okay, lepas tu distributive ke tak? Cardiogenic ke tak? Oxidative ke tak? Semua bukan. Dissociative. Kan? Okay. Okay, continue.
Okay. So, this is
Heterogenic, siapa yang bersalah?
the person who's passing over.
Still, is still, okay, dalam kategori all yang benda-benda tu. Okay.
So this is quite an important concept to understand. Most of your end organ, aside from your bowel, has some form of robust auto-regulation. And in order to maintain proper perfusion, the pressure has to be within the limits of this auto-regulation. Whenever there's excess ataupun insufficient provision of ataupun become excessive to the point of causing congestion, and that causes all sorts of problems. Like we mentioned before, it's usually either the heart, the brain, ataupun the kidneys that's going to start the into that vicious cycle. So the kidney, because it's an excretory organ, the heart because it's a pump, the brain because it's where your regulation of breathing and sympathetic to your sympathetic activity is at. So this kind of things cannot be understated. So if you don't keep in mind the concept of auto-regulation, you're going to cause problem. Typically, the problem is not with the heart or brain or kidney. The typical one that we miss is the bowel, because the bowel doesn't have auto-regulation. So a common example is an intubated patient on some kind of low dose pressure, but not on pressure, who has normal bowel function initially, but you've kept the patient NBM for 3 days, 4 days. What's going to happen to them is that they're going to get gut hyperperfusion, and this causes a phenomenon called bacterial translocation, where you have normal flora that's now causing problem because of weakened host factors. So if possible, account for all these things. Okay, next we're going to talk a bit about cardiac biomechanics. So prelude. So when I was a medical student, preload and afterload was never properly explained to me. So preload is simple. If you look at this actin-myosin diagram, it shows varying levels of overlap the two molecules. So an optimal preload is when you have complete overlap. You have no overlap between different actin and myosin fibers. So this represents an ideal position, an ideal state of fluid status in that patient. If you have too little patient, the overlap occurs, and your cardiac output drops. Your stroke volume drops. If you have too much volume, to the point of overdistension, you have reduced overlap between the fibers, and then your stroke volume also drops. So this is the phenomenon that underlies the graph called the Frank-Starling law for the right ventricle. So this
Dia apa preload banyak.
so if you add volume, they can shift to the right side of the curve before. But if you give too much, they can start to drop. So this is a very important concept to understand, because the debate regarding fluid responsiveness is so far never ending. Different people have very different opinion. What is the optimum volume of fluid that you can give to the patient? What is a safe fluid challenge for a patient? How do you assess whether or not the fluid that you're giving is benefiting the patient? Sampai I think sampai kiamat.
Betul tak suruh you patient tu kan? Patient tu yang dia mana? Dia yang 170 kan? That is very interesting, the patient.
But kita ingat the detail. So
bercerita lah sikit briefly patient tu nanti. Saya bercerita briefly apa yang tahu.
In comparison to preload, afterload is also very complex, but the major manifestation of afterload is quite straightforward for us. In most situations,
Basically, you faham tak apa yang dia cakap ni? Pasal preload. 2 liter pun ham, over pun ham. Simple kan? Okay, so basically kita nak ideal. Okay, banyak pun tak boleh, kurang pun tak boleh. Sebab dalam total dia akan ikut tadi. Senanglah kurang sini tahu, tapi banyak lagi banyak. Sebetulnya kalau you ikutkan lagi banyak, kalau you ikutkan cardiac output, stroke volume ni, sebetulnya tinggi lah kan. Tapi sebenarnya lagi banyak boleh dapat high output failure kan.
Basically, your heart macam is getah punya back. It has a inherent elastic capability. If you stretch it too much, it's not going to it's going to get damaged. If you give it too little, the elasticity is not being applied optimally.
2 liter senang lah, 2 liter you faham. Tapi yang banyak ni, so bagi seorang senang orang faham sikit.
So afterload is also a very complex topic, but again, most of the clinical presentation are fairly simple. The high afterload patients are the one that you encounter as APO, patient yang ada posterior reversible encephalopathy. You have too much of a MAP to the point that your heart cannot pump blood to your end organs, and so you get manifestation of end organ damage. For the heart, it's going to be chest pain ataupun arrhythmia. For the lungs, it's going to be some kind of some kind of pulmonary edema. And for the brain, it can be many. You can ada patient yang pening, you can ada.
Afterload tu macam mana? Apa maksud afterload?
So afterload is the pressure that the heart must overcome in order to circulate blood through the LV outflow tract. So if the stroke volume of the heart, the contractility of the heart is not sufficient to overcome this afterload pressure, then you get no perfusion.
Faham kan?
And again, remember, it's not just about forward failure. If there's no blood going out and there's blood coming in, eventually it's going to be congested, and you get also venous congestion in your problem. Okay. So right ventricle is often forgotten when you assess a patient. All of the clinical teaching that I had as a student are very left ventricle focused. Even among cardiologists, there's rarely one yang focus on the right ventricle. Have any of you noticed your patient yang ada right ventricular MI they don't go through the typical key linear progression. Have you noticed this?
The terus click for kan.
The terus click for. So again, it's important to understand why this happens. Your RV, similar to your LV, can be, you can classify the pathology into pumps, tanks, dengan apa? Pipes. Okay, but in RVMI, there's reduced contractility, so you have to optimize the preload. If you let your preload drop too much, you're not going to get perfusion through the pulmonary circuit, and as a result, there's no, the congestion on the right side is not going to occur in the pulmonary circuit. Rather, the shock progresses into terus kilit 4, because if you don't have blood flowing up through the pulmonary circuit, then you're not going to have blood coming into your left ventricle. So you have to be careful. Patient with right ventricular punya MI, dia takkan develop all of this typical kilit 2, kilit 3 finding. If they do have, it's usually very, very minor. They terus progress to kilit 4. You have to be very careful, especially with when you give them thrombolytics, because the typical occluded branch, the RCA, also provides your SA node, so you tend to get bradycardia as well. And then when you reperfuse back that vessel, it's going to cause a reperfusion injury. So that transient reperfusion injury can introduce a lot of arrhythmia. It's not atypical for an inferior MI and a right ventricular MI untuk tiba-tiba ada brief asystole, asystole VT, a lot of things like that yang you akan encounter in clinical practice.
So you faham lah. So kalau macam tu, kalau macam yang patient SK, so memang kena monitor betul-betul kan. So you can macam bagi SK, tunggulah after 1 hour. So, sebab tu, kalau you masuk ni, kalau you ambil master, kalau master student I dulu dekat UM, siapa-siapa saja, any patient yang on STK, master student kena wajib ada kat situ, tepi patient. Duduk je lah. Then, so because kita nak tengok this one lah, because ada side effect, perfusion semua, BIDP semua tu. So we call it apa? Reperfusion arrhythmia kan?
So another thing, we usually don't give volumes for LVP MI unless we deem it safe to do so. In RVMI, it's quite the opposite. They need volume, and you cannot give them enteral or parenteral nitrates. Okay, so this is very important. But if
even though BP dia high, even though BP dia high. Faham tak? Siapa nama? What's your name? I dah lupa. Kau. Faham tak kau? Lah, contohnya patient inferior, patient MI lah. Okay, inferior MI, right-sided involvement. Severe datang dengan severe chest pain, very typical, sweating, blah 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 semua kan. Okay, so on arrival, patient in pain, severe pain, BP 170/100, heart rate dia 80. ECG, ST elevation, okay, inferior leg, lepas tu dia ada right side inferior, lepas tu ST depression B1 sampai V3, ECG depression. Okay, so maksudnya dia ada inferior and posterior kan, ST depression kan. Okay, B1 sampai V3. Okay, kalau you pusingkan ataupun you buat posterior, dia possible dia akan ada STR. So kalau patient yang massive, this one is considered massive inferior MI lah. Massive inferior MI with right-sided involvement. Okay, so initially BP dia high because of the pain. Kan, masuk constriction semua, all the increase catecholamine dalam badan briefly. Lepas tu kalau you bagi management of MI before you PCI and thrombolysis initial management, dia bagi apa? Aspirin, berlintah ataupun pelvic. Lagi? BP high 170/100. Let's say lah BP high 170/100, adik dia tanky lah. Tanky sikit lah. 100. Selain go GTI. Standard you bagi. Okay, so what happened?
So I think I didn't explain the concept properly. So preload for different ventricles are different things, but for the right ventricle, the preload is the systemic venous return. So this is maintained by the volume within your veins and also the tone of your vena cava. So GTM is a venodilator first and foremost. So if you give it to a patient yang ada RVMI, the patient akan ada venodilation. So that thanks the systemic venous return. And as a result, kalau tak ada, there's no blood going to the right ventricle. There's not going to be any blood going out of the right ventricle. Not going to be any blood coming to the left ventricle.
So you have to be cautious. You have to be cautious, especially patient tu dia ada kalau let's say MI. Okay, if you have MI, you have to be cautious dengan vasodilator lah, venodilator lah, GTN ataupun you nak bagi apa lagi venodilator. Antihypertensive, CCB kan. Okay, CCB yang DVDP tu, tapi verapamil okey lagi. Okay, so you have to be cautious. Tu satu lagi, okay, one skill. You have to be cautious kalau patient tu MI, let's say lah patient tu anterior MI. BP high, hari tinggi kadar, BP dia still 107, patient ECG anteroceptor MI lah.
You mean cardiac wall rupture?
Kenapa you tak boleh bagi, ada certain condition, you tak boleh bagi GTM. Sama juga macam inferior MI. Ada sikit. Saya rasa macam you nak boleh jawab.
It can be anything.
Okay, the voto.
Oh, okay.
Okay, so the voto, left ventricular obstruction. So, okay, nanti you baca macam mana. Okay, so the voto ni, so sebab tu kalau patient MI, especially anteroceptor MI, okay, so BP high, heart rate tinggi kadar. So you have to understand why heart rate tinggi kadar. Okay, selalunya zaman-zaman dulu kita buat echo, kita pernah buat echo untuk dah tengok ada apa nama aneurysm lah kan, because one of the complication of SCK aneurysm. Tapi kalau untuk PCI tak ada masalah lah. Okay, so lepas tu sekarang ni untuk extra step, untuk you kalau misalnya you kalau you dah belajar, okay, so you kena buat. Sebab benda ni kalau you tak buat, sebab kita dah tahu lah kalau, because this one is that affects patient's life and death. So kalau macam benda tu yang very simple, MAPC, TAPC, whatsoever yang tak affect patient's life and death, tak ada masalah. Tapi kalau benda ni, kalau you tak buat, okay, and then you tahu if will might cause worsening, collapse, bila ada benda tu, you kena buat. Maksudnya left ventricular obstruction. So patient dalam anteroceptor MI, so dia punya yang kat bawah tu, okay, kat bawah tu dia kurang bergerak, kat atas tu dia akan hyperdynamic. Bila hyperdynamic kat atas tu, dia akan ada dynamic obstruction. So maksudnya bila dynamic obstruction, okay, so bila you bagi vasodilator, okay, so dia akan worsening dia punya dynamic LV obstruction tu. Tapi itu another story. So for your level, okay, for your level, RV knowing the inferior MI with RV involvement tak boleh bagi venodilator is enough. Okay, for you, kalau dah tahu lepas tu, you can.
No, it's in the presentation.
Ada dalam presentation? Okay, alright.
Another situation.
Tapi tadi you tak boleh jawab.
Oh, no, sebab
okay, tak apa, continue.
Anyway, there's a few more peculiarities of the right ventricle that you have to know. Another one is that unlike the left ventricle, it's perfused during both systole and diastole and at very low pressure. So what might happen is that if your patient has a sudden acute elevation or sudden right ventricular outflow tract obstruction, the walls of the right ventricle might not be able to cope with that sudden elevation and they becomes hypoperfused. So this is the reason why you get all those McConnell sign, kemudian apa lagi? I forgot the other one. Basically, that's parts of your right ventricle.
It's acute lah. Kalau acute yang McConnell sign. McConnell sign is like on the term acute pulmonary hypertension. Terus hanya acute ni boleh je RDS.
Apa lagi? Because I think that's it. So you have to do this because you need to be
Dia
able.
boleh sangat, benda simple je. Okay, dia suka tak ada benda. Simple kan.
So this is Forrester's classification of heart failure. When you see cardiomyopathy patient is warm and wet, ataupun wet and cold, this is the thing that they're referring about. So Forrester's classification is a simple diagrammatic separation of how to manage different phenotypes of heart failure. So those yang ada good perfusion, you don't usually have to give them antihypertensive. Those yang ada wet punya lung, you have to give them some kind of diuresis ataupun preload reduction in order to counteract the congestion occurring at the pulmonary level and whatnot. So for newer MO, this is a very good conceptual.
I think this one is good lah. So you tahu macam mana you nak basically dalam patient MI lah, dia patient MI kan. Suddenly heart failure, sometimes BP dia on the higher side. Okay, so you bagi venodilator. So kita tahu walaupun dia is not based on the BP kan, nampak tak kat sini? Ada tak? No more pressure. Ini kalau cardiogenic shock.
Atas is perfusion, so low BP ataupun
Normal. Okay.
they don't really use pressure, they just ask you to
Okay lah, boleh lah.
so you can have patient yang high BP but poor perfusion, patient yang low BP but good perfusion. It's a point of contention lah, basically. What is the
Okay lah, nice to know.
so but again, it's important not to treat this as an algorithm. You have to think about things that's going on, particularly if you suspect ada right ventricular involvement. This might not apply. Okay, so heart failure with preserved ejection fraction. You pernah tengok patient yang cold, you buat echo, there's good contractility, and you don't understand what's going on. Tapi you perasan the walls are hypertrophic in ways that you're not used to. So heart failure with preserved ejection fraction is like reduced ejection fraction is a clinical syndrome. Usually it used to be called diastolic dysfunction, but then they consolidated their evidence and found out that diastolic dysfunction is not the only cause of heart failure with this kind of failure. So the principal pathology of the heart failure with preserved ejection fraction is that there's concentric hypertrophy. You're used to what we call the hypertrophy.
Sigmoid.
Dilated lah senang. So the dilated cardiomyopathy kan, you buat X-ray, you tengok ada cardiomegaly, you buat echo, the heart is enlarged but the wall is thin. So that's your typical heart failure with reduced ejection fraction. There's not enough cardiac mass to push the blood through your systemic circulation ataupun pulmonary circulation ke, whatever. So heart failure with preserved ejection fraction is different. The principal cause is there is an outflow punya obstruction that is gradual and slow.
So basically faham tak maksud dia? Patient ni clinically heart failure. Tapi you buat echo macam ni cantik je. Okay, so sebab tu sekarang ni kalau orang tanya, kalau kita buat echo, tanya, what's the F? I tak lah, bukannya I macam EF ni is not that important sebenarnya. So contohnya, kalau patient tu valvular heart disease pun, contractility cantik, tapi dia ada heart failure. Okay? So this is what we call it. Contractility dia okay, ejection fraction dia okay, tapi dia still ada heart failure. Okay, contohnya, okay, case macam ni lah. Okay.
So usually there's a slow progressive increase in the afterloop, which gives the time for the heart to remodel itself and it develops this particular kind of LV punya hypertrophy. The textbook example would be patient yang ada hokum due to a bicuspid aortic valve. Dia akan affect dia punya outflow cause jet radium issue possible. So these kind of patients are very, very dependent upon having normal rhythm. They tend to develop symptoms when there's additional exertion. Tachycardia ke ataupun AF ke. So there's this phenomenon called atrial kick. It's when your the contraction of your upper atrium is usually not that important, but in this kind of situation, it is because the LV needs all the end-diastolic volume that it can get. So if they develop AF ke whatever, ataupun you give them basics, you treat them macam typical heart failure, ataupun contohnya you bagi antihypertensive, dia akan cause reduced afterloop, and then because of the reduced afterloop, the flow is increased, you're going to crush the patient.
Ataupun you bagi electrode.
Hmm.
Macam pelik tak? Macam let's say lah patient dia datang dengan sepsis. Okay, so BP dia low, heart rate dia tachycardia tapi tachycardia yang sinus tinggi yang bukan untuk cardiovert. Yang let's say 140 macam. Pelik tak kalau macam kes macam tu kita bagi beta blocker? BP dia low. Tapi kenapa kena bagi beta blocker? Pelik kan? Sebab tu kita kena tahu patient ni ada kena buat echo before you nak bagi electrode, before you nak treat patient shock. Okay, so you wajib kena tahu, okay, first of all, the question is patient datang in shock. The first question is what type of shock? Okay, so you rule out yang the easily reversible. Yang easily reversible is obstructive dengan obstructive dengan yang nak tengok lah yang easily treatable. Apa boleh ni lah you bagi flu kan. Jadi easily treatable is apa boleh ya dengan obstructive release lah. Obstructive ni in the sense of is either kind of carbonate ataupun tension pneumothorax lah. Kalau obstructive secondary to severe AS tu you just duduk kat situ, duduk aja lah. Okay. So bila dah tahu okay patient ni dia ada apa benda tahan sebut apa have ataupun bagi paling simple is levoto. Okay, levoto. So senang sikit. Sekarang dulu have puff whatsoever lah. So sekarang levoto. So tengok patient ni untuk dia cantik macam ni tapi hari dia punya tu tebal. Lepas tu tachycardia macam tu. Okay. So it's either you bagi fluids. Okay, so bila you bagi fluids still macam tu lagi. So you try to reduce dia punya tachycardia because tachycardia yang cause punya BP dia low. So how to reduce? You discuss dengan EP. Okay, what kind of beta blocker you want to use? Sebab ada certain beta blockers dia ada vasodilating punya beta blocker. Okay, the best is esmolol. Okay, ataupun bisoprolol. Okay, metoprolol boleh dapat repeat lagi, dia ada vasodilator. Okay.
So what's going on? So this is the phenomenon lah. So basically with that increased cardiac mass, the contracting.
Benda ni simple je tau. sebab apa tau, you kena belajar sebab benda ni dia affect patients punya management. Kalau dia tak affect, you just boleh let go je. Tapi sebab yang ni dia affect patient management. Tak nak you kena belajar lah paksa. Okay, because you are dealing with life lah. Okay.
So what you medical school, best kita ada belajar laminar tubular flow. So the best kind of flow is laminar flow. So what happens in patient yang ada Hockham ke ataupun ada aortic stenosis ke, because of the increase in cardiac mass, the contractility is so high, it creates this rapid punya flow and causes drag on the medial punya flap of the mitral valve. Because of that, benda principle apa I don't remember that. So that drag causes the mitral valve to be put towards the septum, and this is what they mean when they say dynamic obstruction. So the bottle is LV outflow tract obstruction. The same phenomenon can happen over much further on the right side, but this is the principal reason why the treatment is paradoxical to your typical HF. So this kind of patient, kalau you treat macam biasa punya HF, they're going to crash. Okay.
So basically kalau patient tu you bagi tidur, you bagi adrenaline ataupun high dose NORAD. Okay.
So another phenomenon that I want to talk about is occult shock. So occult shock is not actually a concrete term. I tried to do some searches, but people disagree on what occult shock means. I'm going to present based on the things I encountered like ED. So there's more expanded in your concepts, but these are the ones that I encountered the most. There are three typical situations where you encounter occult shock. Patient yang compensating very badly, but still in that safe BP punya range, you terpaksa intubate for whatever reason, and you sedate them, tiba-tiba pingsan. Another situation is patient yang ada traumatic punya hemorrhage. You got a patient yang ada MVA, you suspect intra-app bleeding, tapi dia tak nampak dekat mana, so probably retroperitoneal. BP dia is 110, 150.
Borderline low lah.
Borderline low, dia punya heart rate is 130, 120.
Tachycardia.
Tachycardia, You ambil the HP, it's 17. Oh, you feel happy, I tak boleh intervene for this patient. Ataupun kalau you minta blood bank, minta blood kat blood bank pun, blood bank tak bagi, and you kata, I accept the explanation, the HP is low. If you have this kind of demand,
Mana dia blood bank tanya PSB,
ada
patient trauma.
tanya, tadi dia tanya.
Sakit.
No, dia pun tanya. HP dia tadi berapa? That's why tak ada heart rate is 140, takkan I tak buat apa-apa. Anyway, so this patient is in clear shock, but if you adhere to the concrete punya medical explanation, you're going to miss this. That patient has a severe intravascular malnutrition, they're losing whole blood, you have to replace whole blood. So kenapa our patient ada trauma tu is stable? So there's this process called capillary refill. Basically, most of your fluid is in your intracellular compartment, and when you have a acute volume loss, that's going to be physiological mechanisms yang play a role in trying to equilibrate the fluids within its compartments. So when you bleed, you lose whole blood, and then when transcapillary refill sets in, your intra volume akan become depleted, but the hematocrit, the content of your protein, your hemoglobin apa semua is lower than what is physiologically acceptable within such an acute phase tu, tak tercapai, and they're going to develop all kinds of phenomena. This kind of patient, they need blood and blood product displacement. Kalau dia tak bagi, they can develop that dissociative near shock. Dia akan develop arrhythmia, dia akan develop sudden success drop, all sort of thing yang macam doesn't make sense in a linear sense, but when you think about it a bit more, there are a good explanation to why it happens. And in the case of an agitated patient, you have to intubate suddenly crash, most of the times because they're young, they have a very capable adrenal reserve. They are
Agitated you jadi intubate
unless it's TBI lah.
I mean TBI. Jadi kalau saya agitated sebab bukan trauma lah, sebab benda lain.
Sometimes you still have to but you have to be aware lah yang kata that agitation is contributing significantly to the sympathetic tone and cardiac output of the patient. You calm them down with sedation, suddenly that fight or flight response disappears, the BP is going to drop, and it's not going to drop macam it always drops precipitously. Sebab tu you have to consider giving fluids first, you have to consider your sedation punya dose yang tries to wrap properly. You have to consider your paralytics as well. Some people, I have a preference not to give scolding in metabolic acidosis patient, because sometimes you tak tahu kata patient tu ada hyper K, and that was the metabolic acidosis because of
nanti aku malah ajar delay dengan resuscitation sequestration.
So this might sound like something yang too advanced for me as a flutter or whatever, but you still have to keep it in mind because it's a potential of serious harm.
Contoh kalau ada je patient yang dulu lah zaman-zaman you tak pandai sekarang you pandai lah. So pernah kan you intubate patient, lepas tu terus sistole. Tak sampai setengah jam terus sistole CPR. So masa so issue dia you all tak resusc properly before intubation. Okay, so intubation is not the end. So basically before intubation you kena buat something, during intubation you kena buat something. Okay, so nanti akan macam delay resuscitation.
Similarly, macam kalau patient on STK, post intubation you shouldn't give the patient at least for 10 minutes.
You
Shouldn't give the patient at least for 10 minutes.
STK?
No, intubation.
Oh.
Kalau you letak
definitely lah, of course lah. So you all jangan leave patient okay.
So another form of shock, which is alluded before, is supply-demand mismatch. So this is the more accurate.
Dia ambil daripada mana ni?
So this is the more accurate representation of tissue level shock. But there are practical problems with it because it's reasonable. We can reasonably infer the state of supply, but the state of demand is much more difficult to extrapolate. There used to be this thing called central venous O2 saturation, introduced during the landmark sepsis 2 punya paper, but then they've discovered that there's a lot of conflict of interest, and that the data provided by the central venous saturation is not really representative of clinical implications, so they have to be scrapped. Since then, there's been a lot of effort to find a replacement for what can properly, adequately represent the state of tissue punya demand in terms of nutrient, in terms of oxygen in particular. So you have lactate, you have that pro-ADM thing, you have I don't think procalcitonin.
So you faham lah type 2 MI. So you nak cakap pasal type 2 MI.
No, ada cakap pasal supply demand mismatch. This is the commonest supply demand mismatch problem that we encounter. Okay,
macam mana dulu dapat type 2 MI? Okay, sebenarnya tak tahulah cardio kat sini tapi sebenarnya type 2 MI, macam mana nak diagnose type 2 MI?
It's a CAF negative diagnosis.
Yes. Okay. So dia only diagnose bila dah buat PCI. So kalau PCI tu dia tak ada atherosclerosis itu semua, baru dia cakap type 2 MI. Otherwise it is semua is because of the atherosclerosis, acute coronary syndrome itu semua yang because of the ada block kat situ. Okay, so dia tak boleh cakap type 2 MI, tapi itulah dia orang boleh cakap lah sebab dia orang cardio. Tapi for you guys, okay, so type 2 MI is only diagnosed PCI negative.
It's inappropriate to have someone yang part of the CPG punya ni cakap PCI is a gold standard, but they don't really do emergency PCI. So question from there. Okay, so when you talk about supply demand issue, you're going to encounter two very frequent parameters. The first one is this delivery of oxygen equation. This is extremely important if you want to get into the academic side of shock management, because this equation underlies so many interventions that we do in ED, in ward, pulmonary, non-pulmonary, whatever, in ICU. So understanding it is paramount. So there's a few take-home messages here. In particular, the only parameter that is usually not readily available in a patient yang ada tissue level punya hyperperfusion is the cardiac output. Okay, so you know the cardiac output is stroke volume times heart rate, and you have the heart rate data, but how do you measure the stroke volume? So that's the underpinning reason for this presentation. We'll go on to later. But if you have that data, you can actually calculate the delivery of oxygen, and you can reasonably make a deduction about how bad the high output cardiac failure state really is. Okay. Another take-home point is that if you look at this data, look at this equation, the contribution of dissolved arterial oxygen is incredibly low. So most of your oxygen carrying capacity is in your saturated hemoglobin. You only need SpO2 for this kind of to make a reasonable deduction on the state of perfusion. On the state of oxygenation. Regular EBG pretty much, I think, should only be done in neurocritical patients where you have a higher threshold of what you consider to be acceptable. But in all other patients, the SpO2 is sufficient unless there's other problem confounding the result of your VBG. So if you don't know, if you take VBG from two different hands while they're doing two different things, the result will not be the same, because that VBG is draining from an active tissue, another one is draining from a resting tissue. So it's going to affect the pH, it's going to affect the PCO2. In most situations, it doesn't really matter, but there are situations where you have to be very strict, and usually that's neurocritical patient. You have to maintain strict PCO2, you have to maintain normal pH, maintain higher than normal O2 concentration. The other equation that you're going to encounter quite frequently is this thing called cardiac index. So this is basically cardiac output divided by total body surface area. So the skin is typically the first organ that gets hyperperfused when you have a shock, because it's being shunted to vital organs. So the cardiac index is a very sensitive marker on the state of perfusion that the patient has. And again, you can get the body surface area of a patient quite easily. It's the cardiac output the cardiac output is the one that's missing, because again, you don't have the stroke volume in most situations. So that's the supply side of things. What about the demand side? So this is another quite complicated concept to wrap your head around, but I'm going to be very brief here. So this is a representation of the cardiac work. So the work of your organ is what determines how much supply that it needs. And okay, so
supply and demand.
Yeah.
Okay, so basically kalau macam you tadi yang cakap pasal type 2 MI, so make sure kalau let's say kalau cardio tu kata type 2 MI, so apa yang type 2 dia? Is it because of itulah supply tu tak ada? Contohnya selalunya type 2 MI because of the supply tu tak ada, and also demand tu tinggi sangat. Okay, tapi sometimes selalunya commonly patient yang boleh dapat MI, contohlah patient because of the supply demand punya mismatch and then dia boleh MI. Okay, macam mana? Sebab contohnya ni coronary dia punya atherosclerosis paruh. Okay, bila dia ada supply and demand punya mismatch, dia akan vasoconstriction. Okay, so yang daripada paruh atherosclerosis tu, okay, so dia dah jadi constriction. Bila constriction jadi macam full voltage. So actually is still type 1 juga sebenarnya, sebab dia ada atherosclerosis, tapi because apa nama orang kata dia exaggerate dia punya nak kata because ada supply and demand tu lah. So basically kalau you nak kata make sure you what the trigger. Okay, what the trigger of the MI. Macam sometimes patient MI tapi patient anemia, you tak risau cardio. Kan? Sebenarnya patient tu sebenarnya memang dah ada atherosclerosis. Kalau buat PCI kemungkinan besar ada atherosclerosis, tapi sebab because of dia punya supply to reduce, okay, vasoconstriction. Okay, so basically what the causing vasoconstriction dalam coronary vasoconstriction tu. Okay, so that's what dia cakap pasal supply and demand. Faham? Okay.
But this applies to other tissue as well. The actual point yang I nak tunjukkan with this graph, you have two types of work inside this PV loop. This area under the curve, you have stroke work and you have potential mechanical work. So this potential mechanical work is actually not efficient work. So when you talk about shock, you have different stages. Typically, you classify as compensated or decompensated. What usually happens before shock becomes decompensated is this: there is greater inotropy. This PV, this thing is called PV loop, becomes more narrow, and when it becomes more narrow, the stroke volume drops. But the ratio of useful and not useful in your energy span is increased. You understand what I mean? If this line moves to the right side, okay, so if this line moves to the right side, the area under the curve is still the same, but the efficient work, the ratio of efficient to not efficient work increases. Eventually, the stroke volume is going to drop so much to the point that it can't supply perfusion. And this particular point is crucial, because this is when you get decompensation. It's the same for any organ. In a state of hypermetabolism, the supply the supply is not being efficiently used. Okay. So if you don't intervene, you're going to let the patient progress into decompensation. This is the other factors yang Dr. Hafizuddin cakap tadi. So you have phenomena outside of the 4 typical classifications of shock, and you need to pay attention to them. And a lot of this has to do with bowel punya function. Okay, the heart requires free fatty acid, requires lactate, requires ketone bodies and whatnot to keep it functioning. And if all you do is provide IV drip for the patient without considering the nutritional punya requirements, the daily calorie intake apa semua, eventually they're going to use up the supply much faster than usual. Then you have your electrolytes, things that affect your contractility. Calcium in particular, selalu orang lupa. You need calcium to be able to do proper contraction. If your patient has hypocalcemia, you bagi pula beta blocker, you're going to cause, you bagi pula calcium channel blocker, you're going to cause a lot of problem. If you don't address acidosis, that severe acidosis might cause cardiac depression, might cause sympathetic punya denaturation. As a result, you get abnormal vasculature. Alkalosis is also not good. If you remember, that's that oxygen dissociation curve. So a bit of acidosis is helpful in offloading oxygen, but alkalosis causes the hemoglobin to retain that oxygen. So again, that might worsen shock on the cellular level, but not be detected on the personal level. And then you have your endocrinological consideration. We've been starting patients on steroid, 50 milligram QID ataupun 200 milligram over 24 hours. So the reason is as adrenal support and immunomodulations, but sometimes it's the host punya immune system yang is actually contributing to the deterioration that the patient is suffering.
Okay, faham Saya tak faham tanya. Okay, I think that one okay lah. Faham? Tak tahu pun tak apa. Tapi you kena faham the concept. Yang penting konsep dia faham. Okay, sebab kalau you tak identify yang shock or apa, because dia benda ni yang, so kalau benda tu yang benda macam as simple as like macam tadi lah vasodilator kan, bagi GTX. Simple je, bagi GTX dalam patient yang paling standard lah kan. Zaman-zaman dulu Mona is died already kan. So tapi still kita practice GTX kan, as simple as GTX. Bagi GTX patient BP crash. Maksudnya we cause more harm to patients. So our job is first of course lah we take the patient and we should not cause further harm. Okay, that's why we need kita ada safety ni. You sign up for this sign up to be a doctor you need to learn. Okay.
So this is a simplified presentation of different organ, their perfusion ratio and their perfusion pressures at normal state. So you can see there's a very wide swing changes as you go along the circulation. So your pressure is 100 millimeter mercury and your organ perfusion pressure is about 50. But because they are arranged in
the medical student lah, they distribute lah.
So if your venous pressure macam patutnya kat sini 20 mm mercury ataupun maybe 10, if it suddenly elevates because of congestion, it's going to affect the perfusion pressure. Same goes to your right ventricle. If the perfusion pressure is very low, if you see here, it's 20 to 30 during systolic, 3 to 7 during diastolic. If the pulmonary artery pressure suddenly increases up to, let's say, 30, 40, you're going to have right ventricular issue. Same principle applies. It's afterload, it's preload, it's endostolic volume. It's the same thing, recycled over and over again. It's just about where you apply your knowledge and how do you use that knowledge to modify your understanding of the presentation that the patient is having. So that's going to help you delineate between all these causes and what needs to be done in order to stabilize that patient. Okay? All right. Okay, so so some pernah buat this thing, this passive lateral testing. This was really popular during the early phases of COVID, and then it's died out. Okay, so passive lateral testing, the logic is simple. You want to test volume responsiveness, but you don't want to introduce additional fluid. So you raise the leg, and that causes the blood within the venous system of the leg to pull down into the trunk. If that patient cannot tolerate that volume, you can just reverse it by reducing back the patient punya leg. Basically, make the life supply again lah. As opposed to kalau you bagi fluid, kalau you nak diurese, nak bagi diuretic, the same volume it's not necessarily gonna come out. So the passive lateral test is considered the gold standard of fluid responsiveness. But anyone, whoever does it, akan tahu the obvious problems with passive lateral test. You have a patient yang tengah agitated ataupun the patient yang tengah compensating kan, you pergi angkat kaki dia tak tahu juga buat apa, it's going to cause a lot of problem. If the patient is obese, you need a lot of people to do it. And then you need to monitor the effect of your intervention, which means someone has to hold the ultrasound.
Physical assessment of shock ke ataupun
Physical.
physical assessment of shock? Physical assessment of shock is CCTVR.
I mean,
Tapi yang ni is more to volume responsiveness.
no, I include the response to therapy as well as a part of your physical assessment.
Sebab yang ni untuk kita tengok patient ni volume responsive ke tak volume responsive kan? So, maksudnya
No, the point that I want to say actually, you have to be careful about the term gold standard. Until you buat something and you don't know the associated issues. It's okay for you to read and macam rasa ada trouble ni, but you have to be aware of what the implications are basically. You tak cukup softness, you tak cukup MA kan. You don't have time to do these things. You don't have time.
paling simple lah bila tak macam susah lah kan patient OP seterusnya. Paling simple, paling senang lah yang buat. Selalu yang kita boleh buat previous kali tu. Tak lah. Satu lagi. Yang BP, standing lying. Kan? Sama juga. Sama je. Prinsipal sama je. Kan? Ataupun sitting sitting and then lying. Okay? Sama juga. Okay? So nak tengok ada discrepancy tak? So ada discrepancy maksudnya ada postural lah, postural hypotension maksudnya kalau very marked, okay, when patient datang dengan evidence of shock, okay, so possible patient ni shock lah. Macam dengue semalam hari tu kan sepatutnya buatlah yang sitting lain, standing lain. So kita macam CCTV okay, tapi BP on the lower side. Patient dizziness lethargy, something like that lah. Dizziness, lethargy, BP on the lower side. Tapi hari ni tak taki. So macam orang shock ke tak shock? Kan? So dengue in shock ke dengue tak in shock? Okay, so paling senang you nak tahu patient ni in shock ke tak yang tadi lah. Okay, so this one is gold standard kan? Okay, kalau yang susah sangat you just ambil BP lying and supine. So ada discrepancy patient in shock. Walaupun you clinically patient doesn't look like shock.
So this thing was taught in medical school and it still applies today. There are 3 main physical windows into shock. It's your mental capabilities, it's your kidney function, usually in the assessment of your urine, and then there's the skin punya assessment. So it's good if you know ultrasound, but this is what comes first. Okay. If you have, let's say macam that dengue case kan, even if you tak buat ultrasound but you do this kind of things, most of the time you're gonna be macam it's gonna be considered as an acceptable mortality because you dah buat all the things yang outlined in strategi that is prescribed to be standard of care. Okay, so this is important. You want to accept perfusion, you have to know how organs manifest good perfusion dengan malperfusion. So the skin mottling score is what most ICU use now. We check the needs, but that's one of the last places to be to show evidence of mottling. And if you see evidence of mottling, it can be in a bruising punya colour ataupun it can be.
Tak ada satu patient tu, patient barusan stable je, tapi dia punya motor tu memang teruk gila kan.
If you see macam saya tengok dekat kita ada cakap your BP measurement has to correlate with your clinical assessment. If one does not correlate with the other, you have to be vigilant. You have to find out kenapa dia tak correlate one way or the other. But the clinical perfusion marker is what's more important in a considerable degree because sometimes patient tu just sihat kan, muda-muda, kurus, badan tak besar sangat. What do you expect the BP to be in? So it's your clinical perfusion marker is what's going to determine whether or not you place that patient into shock or non-shock category. And in shock, is it compensated or decompensated? So very important to know. So brain mostly in terms of alertness, it's not just about the GCS being full. GCS is not a complete neurological examination. You have to ask other things. Ada symptom tak waktu dia jalan? Ada any change in behavior ke tak? Ada manifest dizziness ke tak? Benda-benda macam tu. So all these patients ada full GCS. But if that's all you're looking into, you're missing a lot of things. Then urine, you have your adequacy in terms of volume, color dia concentrated ke tak. So pretty typical things. In patient yang you suspect ada space loss, you might want to check albumin as well. Tengok maybe dia ada nephrotic syndrome ke whatnot.
Skin color, mottling kan. Mottling, okay, so ni dekat mana you tengok patient mottling? Dia kata patient in shock kat mana yang nak tengok motor ni? Ha? Drum? Lower limb? So kalau kena tengok tak baby kalau sejuk, dia motor je. Kan? Tapi ni dia tak motor. So dia kan kalau macam because of the cold kan, sejuk ni kan, ada je orang motor because of the cold. Okay, so really is peripheral, takut yang exposure area. So dia akan motor tu dia akan start daripada peripheral, tapi patient sangat-sangat well. Okay, lepas tu dia tengok dia ada motor semua. Tapi yang motor yang shock ni dia lain. Okay, dia biru lain because of reduced pollution tu, lepas tu vasodilatation. Bukan vasodilatation, apa benda tu? Vasoconstriction. Tak, dia punya, kalau you tengok, okay, so dia, kalau you tengok baby, so you kalau you tekan, motor dia lain dengan motor yang shock. Okay, kalau you tengok motor yang shock ni, satu lagi, okay, vasoconstriction, satu lagi dia punya tisu tu dia leakage. So dia you akan rasa kalau motor baby tu dia nampak jari-jari. Sama juga jari-jari juga.
Dia non-blanching.
Yes, non-blanching. Okay. So kalau baby dia blanching kan. So kalau yang motor yang shock ni dia boleh rasa. Boleh tengok dia macam non-blanching. Tengok tekan ada lagi. Tekan ada lagi macam purpura. Okay.
So this is a pretty typical scenario. No matter where you go, ED ke what ke apa, quite typical. You ada just a small drop in BP, but now it's no longer a single digit systolic, and now you're panicking. Anak pas over lagi, especially around how do I explain why the BP is low, but the patient looks totally well. So you have to know the limitations of your monitor. So the gold standard of non-invasive BP measurement is your correct cough sound. Okay, so your correct cough sound is not a simple procedure. There are 13 things that you need to be aware of before you take a manual BP with correct cough. When you do automatic BP, non-invasive and typical monitoring yang kita guna, we don't control for all these 13 things. Patient kadang-kadang gerak apa semua. The monitor only measures only measures the mean arterial pressure, and the systolic data and the diastolic data is derived from some algorithm. The algorithm is different by product unit, by brand, so there's wide variation in terms of what beds to display. The only true measurement is the mean arterial pressure. So macam case yang kau present kan, the map is pretty much the same throughout the stay dekat ED. Ada five data semua, I think it was 70-75% juga. But there's a swing in terms of the systolic pressure, which is not coherent dengan patient punya physical assessment, even especially considering that she got 1 liter throughout dia punya stay dekat ED. So again, your measurements have to correlate clinically. So kalau you need to explain to someone why you prefer to just chart map ke apa-apa, this is the reason why. Automated non-invasive pressure monitors don't measure correct cough sound, they measure the mean pressure, and they only derive the systolic and diastolic data. However, you need to keep in mind if things go wrong, so again, clinical assessment is what's going to save you. If it's going to be what you use to justify your decision.
Satu lagi, based on the patient punya baseline. Kalau patient tu tahu dia punya baseline, contohnya patient adalah hypertension. Baseline dia standard 160, 160. Dia datang dengan normal BP for you, okay, tapi dia datang dengan dizziness. Maksudnya dia dah ada hypoperfusion. Okay, so sebab tu ataupun kalau macam patient tu memang standard BP dia 90/60. So BP dia normal, tapi kalau dia then dia tak datang dengan dia datang dengan benda lain lah, fever ke apa ke, janganlah treat as shock. Unless kalau macam tadi lah, macam dengue contohnya, fever apa semua, okay, dia kata baseline dia 100/80. Lepas tu dia datang dengan 90/70 ataupun 90/60. Lebih kurang lah, dia punya tak ada beza sangat. So and then kalau you tak sure, then go to the yang BP lain yang standing tu. Okay, so sometimes macam ni baseline BP dia memang macam tu, tapi dia datang dengan fever, dengue pula tu, dengue tu sangat-sangat takutkan, especially very young, actually adolescent, okay, yang mati, banyak mati sebab patient tu well. Sebenarnya orang yang mati sebab yang tak well tu ataupun extreme age ni sebenarnya secondary punya infection, bacteria infection. Okay, so yang mati yang well, dia takut sebab benda tu easily managed. Okay, so kalau you tak sure, you just ambil je BP lain supply. Okay.
And lastly, with regard to physical examination, charting is very important. It's also important to have a comparison because that's what's going to determine whether or not the patient is following a trajectory that you intend them to follow. If you buat examination but you don't record and then you pass over, and then the pass over punya person tak tahu what was the condition before, suddenly they check the bleeding, was that there before? Was it worse? Was it better? So you don't know. Being able to chart is an important tool in defending yourself against accusations of malpractice. Other things that you need to chart frequently, but we don't do it, is temperature punya charting. Janganlah buat more than twice a day. Apalagi your perfusion punya charting, your at least you check the CRT of that patient.
Ideally itu memang sebenarnya bagus, tapi itulah because of the tak cukup orang kan, ramai patient pun ramai, so ni kita tak, the best kalau you buat tu memang bagus sebenarnya, sebab because yelah patient punya management kan, so bagus lah kalau you buat tu. Tapi kalau macam tak boleh juga, at least batasan, okay, at least ada batasan, kita nak tengok dia punya trend. Okay.
So tadi I cakap I takkan touch about sepsis, but this is but I will try to touch it because this is something yang important for you to do as a junior punya MO. So this is called the SIRS criteria. Back in the days, it was called sepsis RMA. In revisionism, it's now called sepsis 1.0. So this is the original sepsis classification. So sepsis at that time was 2 SIRS criteria with a definite source of infection. Automatic sepsis, patient tu kena admit, bagi antibiotic, and then discharge once they ada good punya control. Sepsis 2 added a lot of things, but they were still sensible. When sepsis 3 came up, kalau you guys tak tahu, it's very broad. Not broad. I mean, my commentary on the whole sepsis 3 punya drama is that it's very entertaining. You see argument all the time.
Tak apalah, whatever. Apa-apa je benda yang tak normal, you rasa bukan osteotic shock, bukan shock ni, sepsis je lah. Sometimes, okay, sepsis kan presented with normal temperature kan. Lepas tu patient rasa feverish. So kalau macam dia ada at least satu evidence, satu je. Contohnya, tachycardia, rasa je, tachycardia. Okay, so kalau you kata sepsis ni, apa-apa je ada satu pun dia kira sepsis je tak?
The point is not that you have to admit all of them. The point is you have to ask more questions. You have to stratify your patients.
Nak admit ke tak?
Nak admit ke tak. So if you macam layan different age populations the same, you're going to cause problems eventually. Okay. And the most important thing about sepsis, in my opinion, is source identification. If you're the kind of MO yang tak banyak tanya soalan and everything pun you occult shock kan, and patient tu get standard tak properly work out, admit terlambat, it affects the outcome. So occult shock is not a diagnosis that you should make lightly. Should be after a comprehensive review of history and physical examination. Most of the occult shocks are going to be.
Bukan bagi diagnosis occult shock, tak ada lah kan? Dia tadi kadang macam tak jumpa. Occult sepsis tu okey lah juga kan? Kalau occult shock ni macam.
Yeah, occult sepsis. So the problem with occult sepsis is mostly going to be intra-abdominal sepsis. You can do a great neurovascular, subcardiovascular, pulmonary dengan peripheral punya exam, but the abdomen is difficult. You don't have a cheap, accessible modality for the abdominal punya source of sepsis, and it matters because some of the sepsis are surgical punya sepsis. If you don't drain it, you don't remove it, it's going to continue to seed infection eventually the patient will collapse. And the gold standard for diagnosis of intra-abdominal sepsis is an abdominal CT. And you all know the problem with getting an abdominal CT. So I don't have to elaborate any further. So most of these patients are not properly cared for, especially by I don't want to say radio lah, but they have to. I mean, they have to lower the threshold. Kalau you plan to go to radio, you have to take some consideration. Even the new punya guideline on critically ill patients with fever, they recommend CT over ultrasound punya ultrasound as a way to identify source of sepsis. Okay, so now we came to the ultrasound part of the presentation. So the purpose of ultrasound in shock is the same as in with the physical assessment, but it represents an expanded tool that you have in your kit. So with just history and physical, you might miss a lot of things. With ultrasound, to complement your examination, you can prevent those misses. Okay, so be aware though, if you are the sort of person to focus on ultrasound and you decide to chart an abnormal finding, you have the responsibility to, how do you say, reasonably investigate that abnormality. There was I remember an incident 2 years ago or 1 year ago, an MO, one of our MO, tak ada kat sini dah, made the diagnosis of splenic abscess. Patient with fever, splenic abscess. Refer kat GS discharge, kata no evidence to suggest splenic abscess.
Tapi dia tak buat ultrasound.
Dia tak buat formal ultrasound. So patient kata GS clear, so I pun balik. Patient balik mati. And if you actually see
You balik?
No.
Dia tak splenic abscess.
Dia nampak something abnormal. Dia rasa tu splenic abscess.
Dia scan lah. Okay lah. So basically ada evidence lah.
But the problem with our ultrasound is that it's not legally binding. So they are not going to act on it.
Zaman-zaman dulu yes lah. Zaman-zaman dulu kalau tak tahu nak zaman sekarang macam mana. Zaman-zaman dulu EP buat IFAS pun dia orang macam IFAS positif. Okay, sekarang ni okay. Dia akan tanya balik. So sekarang I think so kalau dia orang buat positif pun dia orang dah okay dah pun.
But if they're not okay, you have the responsibility to follow that path through. You have to make sure that patient is safe for discharge. So that's the burden when you do this kind of things. Okay, so we have talked a bit about the advantages and disadvantages. It represents expanded tool set. It's non-invasive. It's accessible to us. It's cheap.
You look smart.
But it also comes with sets of disadvantages that you have to consider. Even among those who are proficient, people tend to argue about findings and how best to do an examination. For example, the assessment of lung point, let's say post-trauma, when you place your probe. Some people cakap, okay, kalau you tak tepi, some people say you have to put it at the most superior portion of the thorax. There are pros and cons to both, but just to say that even between those who are proficient, there's dispute. Another issue is that sometimes your finding are affected by that acute illness. Your interpretation of that finding in a super input in an entity might cause you to misattribute the patient in your presentation is something that actually has been there for quite some time. So this is quite a theme when it comes to stable valvular lesions yang ada superimposed acute illness. So sometimes you may misattribute the state of shock to the valvular problem, when in reality the hemodynamics induced, let's say, by the sepsis is what's causing that patient to develop that dynamic LV outflow tract obstruction. There are things that we don't have a good, similar to the criticism yang we don't do frequent enough monitoring. There's no way to macam betul-betul upload our scan findings so that other people can appraise it and determine whether or not they need to get a formal ultrasound. If you do have that system, it would be preferable, but it's expensive and it's not feasible for the purpose of me. And actually, we can bring daripada machine ultrasound too, but I don't know how to do it. And lastly, the issue is with privilege. Open any ultrasound textbook, point of care ke, non-point of care ke, most of them will have this statement in advanced punya ultrasonography, consultant level, specialist level. So sometimes you may appreciate findings yang considered to be a consultant or specialist level finding, but before you intervene, you need to confirm those kind of findings, because if not, if something happens, it turns out your interpretation is incorrect, you are liable to kita punya medical legal disciplinary actions.
Contohnya sini lah, as simple as contohnya trauma lah, trauma fast scan dia saja. Okay, contohnya lah, okay, MO buat fast scan negatif. Okay, so lepas tu turn out actually dia positif. MO tak salah. So because you tak ada, orang kata liability is not on you. Tapi kalau EP, okay, so kalau EP buat, sebenarnya dia positif tapi dia cakap negatif. So dia liability on the EP. Sebab dia expected to do that one. Okay.
So there's a very important caveat that you have to do with ultrasound assessment of hemodynamics, and that is patient on regulators ataupun any other forms of positive pressure ventilation. So going back to the term fluid responsiveness and why it's a very controversial term. Yes, if you have a positive intrathoracic out.
Panjang you punya topic short ni.
You buat IVC ultrasound in an intubated patient, it's not the same as a spontaneously breathing patient. You can't make the same conclusion. So just know that if you put a patient on positive pressure ventilation, if you want to make a conclusion that the patient is fluid responsive, you have to be a bit more careful, you have to be a bit more specific, you have to be a bit more vigilant, you have to know what you're doing. Okay. So when we assess patients for shock, these are the 4 things that we, 4 compartments, 4 locations that we look for. So you have your heart, you have your lung, you have your vascular system, and you have your abdomen. So what are the pathologies that may explain kenapa patient ada shock? Since this is the thing that we do every day, I'm going to speak through them quite fast. So vascular punya ultrasound, for veins, what we're assessing are basically 2 things. Whether or not the veins can function further as a capacitance punya vessel. So capacitance refers to the ability of the veins untuk macam dilate and accommodate whatever fluid that you give to them. So if you buat ultrasound IVC dah kan, there is concern about capacitance, meaning that kalau you bagi patient ni fluid, the IVC might not be able to expand further. So your conclusion is not safe. When you nampak collapse, it's clear cut. Another thing that you look for in venous ultrasound in a patient who is in shock is whether or not there's deep vein thrombosis. But it could be PE or whatever, depends on the clinical scenario. This is important to stress again. Patient yang in if you're diagnosed patient in hypovolemic shock, particularly if it's a hemorrhagic shock, but your scan, you record kat situ, IVC dia nampak besar. It doesn't make sense. Okay? If you want to say that someone has hemorrhage ataupun hypovolemia, but the IVC is big, something doesn't make sense. Must be something you have to investigate further, whether or not there's an overlapping syndrome ataupun the typical scenario is patient yang cakap, I darah hitam, my lipido, you treat as upper GI bleed. In reality, that patient ada hitam because of the anemia and has developed some kind of functional heart failure because of the anemia. You bagi fluid to that patient. Okay, so again, hypovolemic shock. Make sure the veins can capacitate whatever fluid that you're going to give them. Ini macam tadi. Okay, another, so for artery punya assessment, you're basically looking for the aortic syndromes, dissection, aneurysms, ataupun ulcerations, and then you want to check the abdomen, tengok ada free fluid ke tak. So because if you suspect the patient shock, that blood has to go somewhere. The typical punya limitation is of course the thoracic punya assessment of the aorta. The ribs, sternum impairs your ability to view them. You have to do an esophageal ultrasound. You do have to probe, but it's hard to do. It's impractical. So the typical scenario is we refer dekat surgical
Apa di dissection?
Dissection kat aneurysm kan.
Boleh ya. Ada surgical tak tolak, surgical tak tolak lah.
Selalu record sekira JGP tumbuh masuk.
Macam ada within this month, patient dah the two case you ingat the two case diagnosed leaking aneurysm kan? They are seen by GS.
Okay.
It's the same person. Macam jadi in this month jadi balik.
Macam orang tak mahu ambil apa?
No, I mean it's the attitude of the same person. Patient ada sebenarnya patient do case of abdominal aortic aneurysm. Dr. Zulfakar measure ada 2 cm increment in 6 months. Dia tolak ke medical, dia tolak ke surgical, dia tolak ke everyone. 24 hours later baru decide kata maybe aortic syndrome. You know the case kan? No, I mean Abuza. It's the same.
Dia tolak medical?
Dia kata ni ACS sebab patient the chest pain.
Actually depends lah. Tapi itu kena EP level lah. So contohnya kalau macam yang itu, kalau I tengok leading, sometimes I don't fight much because kita tahu the outcome macam mana. So that leaking extensive patient umur 80, tahu macam mana, tak apa, nak tolak medical tak. Macam tu lah. So we only fight kalau benda tu it makes a difference. Contohnya patient tu young patient, okay, and then patient BP dia okay lagi, patient no comorbidity, leaking dia orang kata boleh, basically risk to die on table tu ada tapi not that as bad as very extreme age. Contohnya kita pernah memang fight betul-betul yang patient umur 40 tahun. Umur 40 tahun, dia memang dah call, dah suruh ni. Buat CPR dah pun. Okay, so dia ada aneurysm. Aneurysm sampai extension, sampai dekat dia punya abdomen. Memang sampai ke sedang. Ambil heli dari sini, daripada Jitra. Daripada Jitra, kita terus daripada Jitra, terus hantar sini, scan sini, lepas dari sini, terus naik heli, kau kita sedang. Within like 10-12 hours. That's how you need to fight for a patient. Okay, so kalau setakat patient ada dia, you know the outcome macam mana. So tak apa lah, saya kata kan, memanglah kita kata OGS ni kenapa lah tak ambil ni. Benda ni clear cut kot. Okay, tapi what's the aim? What's the end goal you want to fight for the patient? Okay, so it doesn't make any difference. If it doesn't make any difference, walaupun clear cut lah, memang clear cut gila-gila lah, benda ni is like GS. Okay, so tapi it doesn't make any difference. Apa lah, it's up to them. Kalau kita buat balik lah kan. Okay, tapi untuk this one, I think that section. Okay, I think that section kalau especially in young patient, okay, so patient ni usually is dia punya mortality is lower than aortic dissection, aortic aneurysm, leaking aneurysm. Okay, I mean easily dia punya treatment tu lagi
just best medical therapy.
Tak semestinya.
Kalau dia Stanford B.
So dissection kalau level atas dia Stanford A tu. So easily it depends. I pernah je dah fight dissection, muda juga, umur 40 tahun. Okay, kita fight daripada Zitra kita tak hantar sini. Kita hantar sini terus fight, terus ke hantar Penang. Kita Penang, hari yang the next day dia buat op. So what patient tu? So basically, you know which kind of patient you need to fight really hard. Okay, so you dah tahu lah patient ni, okay, contohnya ada patient ni in shock tu semua kan. So you need to fight for the patient. Kalau you tahu end goal dia akan make the difference. Okay, kalau setakat tak make a difference tu tak apalah, it's okay.
Next we go to lungs. So this is typically the first one that you get taught for because it's not part of your first exam. So
IFAS.
So this is your seashore sign and your stratosphere sign. So the point of interposition, the change between seashore to barcode sign is what we mean when we say there's a lung point. So that lung point is very specific for pneumothorax, but as a whole, lung ultrasound for the assessment of pneumothorax is only useful as a rule into. You cannot rule out pneumothorax. You have to do an X-ray, and unfortunately,
X-ray.
At least an X-ray. You know,
Betul-betul nak rule out.
I mean thorax, city thorax.
City
But
thorax.
you can reasonably increase sensitivity. It's just the issue that they won't do a lateral
Tahu tak
failure.
increase sensitivity in X-ray? Increase sensitivity ada salah lah increase sensitivity. X-ray lah sensitif kan? Okay, contoh ada kan patient chest X-ray normal tapi dalam ultrasound dia ada pneumothorax. Okay, actually dalam ultrasound ni senang je. Okay, of course lung point is like you nampak je lung point okay lah. Almost 100% is pneumothorax. Okay, so how you scan for pneumothorax? Okay, so this one tajuk dia shock. Okay, tajuk shock sebenarnya kalau shock ni tension pneumothorax. Tension pneumothorax is by clinical, not ultrasound. Okay, ultrasound tu just to confirm you punya clinical finding dia. Tu je. So by clinical, you rasa patient ni tension pneumothorax, then you confirm by ultrasound, oh ada tension pneumothorax. Then chest tube without the chest X-ray. Okay, ataupun you suspect tension pneumothorax, you scan, oh ada massive very pleural effusion. Tension pleural effusion. Patient pleural effusion intention lah. We say massive pleural effusion and then patient ada mass effect. So basically you want to confirm. So how to do scan in INFAS, in ultrasound, very simple sebenarnya. Okay, zaman-zaman dulu you tengok, you belajar, okay, first you tengok apa? Sign. Lepas tu seizure ke bakut
Stratosphere.
stratosphere ataupun bakut lah, I mean seizure ataupun bakut. Okay, lepas tu sign, seizure bakut, lepas tu kita tak. Okay, apa lagi? Lung point. Okay, satu lagi lampau. Ada 4 benda. Okay, so ketesan not necessarily. Okay, so kalau, okay, so benda-benda ni, so zaman dulu yang tengok ni, daripada sign, lepas tu bakut, lepas tu lampau, lepas tu lampau. Okay, so sebenarnya untuk shortcut, untuk you punya shortcut, kalau tak nak buang masa, you ambil ultrasound, you terus remote time. You nampak je apa nama? Seizure move. Okay. Bila you nampak bakut, then baru you stay. Okay. Paling senang kan? Okay. Sebab seizure memang confirm dah. Seizure memang confirm tak ada pneumothorax. Bila ada bakut je, then baru you stay. Sebab you nak tengok. You tengok ada 2 benda. Okay. Bila seizure, bila apa nama? Bakut. Okay, so 2 benda nak tengok ada pneumothorax ke tak. Okay, so it's either patient tu ada lung point memang confirm pneumothorax. Satu lagi lung pulse. Okay, ada presence lung pulse? Lung pulse tak ada pneumothorax lah. Contohnya patient tu ada bronchiectasis ke, ataupun patient tu dia ada apa nama boleh ke kan. So tahu tak lung pulse apa? Lampas tak? Amazah, tahu tak lampas? Lampas. Okay, tak pernah kita buat ultrasound. Okay?
Some of the things that may explain presentation condition is contusionalized. So this is a bit misleading. Contusionalized, basically the disappearance of your pleural interface. So this is
Basically, you nampak bilai. Okay, next. Cepat-cepat sikit.
so bila you suspect in congestive heart failure. So consolidation may explain, may provide you with a definite source of infection. You can also think maybe ada pneumothorax kantor.
Subpleural
Efficiency.
Okay.
So this is
Basically, you want to see the source of satu lah ultrasound ni. Satu lagi, you want to see is there any evidence of tension pneumothorax lah, shock ataupun massive pleural effusion, in shock juga, ataupun you nak tengok the source of infection. Kalau infection tu septic shock. Okay, next.
you might be able to identify complex pleural effusion, which require a bit more difference.
Yeah, the seaweed sign. Yeah, it's called seaweed sign. So once you nampak seaweed sign, tak kisah ascites ke apa ke, seaweed sign maksudnya dia chronic. So kalau contohnya patient ada pleural, massive pleural effusion. Okay, so memang in shock. Tak nak, then you need to remove the mass effect punya tu massive pleural effusion. Patient dah tachypneic lah, hypotension. You nampak septic tension tu. So maksudnya benda tu chronic. So macam how you tackle that one? Sebab kalau you remove abruptly, patient akan lagi worsening shock dia tau. Dia akan lagi worsen dia punya condition, lagi hypotension, lagi hypoxia. Lepas tu patient collapse, lepas tu you can intubate, lepas tu patient error. Okay, so how you manage? Patient in shock, BP low, patient tak kidney. So you dah tahu lah patient ni dia ada in shock lah. So you still massive pleural effusion causing shock. Ataupun patient dia ada massive ascites, boleh je. Massive ascites boleh dapat causing shock. Macam mana massive ascites causing shock?
Abdominal compartment syndrome.
Abdominal compartment syndrome. Cekam sangat very tense. Lepas tu dia compress dia punya inferior vena cava. So causing hypotension, diaphragmatic splinting. Dan patient dah hit so in shock juga. So tapi how you tackle that one? Hafizuddin. Patient, okay, we're talking about massive pleural effusion, chronic yang ada separation ni.
So you can give intrapleural urokinase ataupun streptokinase to lyse the clot. If you have an acuity, a need for macam immediate removal of this complex ni, you can do manual punya separation whenever you can. Or you can do macam combined strategy, you bagi intrapleural spectro ataupun urokinase, and then you can check how to.
Dia tak ada lah kat situ, kat ED. Yang paling simple, patient dah sakit ni and BP low. But you need to release, you need to take, you need to treat the shock.
You can consider saline infusion untuk yang dia macam, you know what is intraperitoneal tablet.
Therapy je, very simple. Tapi therapy, okay, sebab kalau you buat chest tube, okay, patient akan collapse. Kalau you call SP, dia kan chest tube lah, benda ni memang gaya chest tube, benda ni massive kot, chest tube lah. Okay, so you have to understand, bila patient dah ada septation, benda ni dah chronic, dia initially dah ada compensation, tapi at the end of the punya compensation tu, dia dah optimum compensation tu, dia dah tak boleh compensate, dia akan drop graph dia. Okay, so bila dia dah compensate, okay, so maksudnya dah lama dia dah get used to it. Okay, so bila you suddenly you remove dia punya pleural effusion, terus buat chest tube clot macam tu, what will happen? Dia ada re-expansion pulmonary edema. Okay, so patient akan dapat hypoxia. Lepas tu suddenly apa lagi? Re-expansion pulmonary edema lagi. Macam mana dia boleh dapat intravascularly depletion juga? Sudden drop of BP.
Yeah, you correct the ventilation perfusion mismatch. Macam suddenly dia akan ada expanded punya pulmonary volume, so causes the capacity of the vessel to go up and get reduced pressure.
Yes. Okay. So sama juga. So patient ni, so kalau dia boleh dapat patient pulmonary edema and also hypotension kalau you buat chest tube. Okay. So same goes to chronic ascites, tapi dia datang dengan tension punya ascites. Still you need to release, tapi you release slowly. Okay.
So this is a semi-regular finding which dekat ED. You have to be particularly careful about female patients yang young. So they can have macam the slow bleeding ectopic, and over time some of the bloods have clotted and they have a different appearance on ultrasound. So this is called hematocrit effect. You see in CT, you see in ultrasound, kayu pernah tengok yang acute on chronic punya SDH2. So the difference is caused by the different areas of blood of the red blood cell. So this is blood until proven otherwise. Yang nampak hitam ni probably also blood. It's just very slow to the point that some of the bloods have had time to clot. And in young patients, it's ectopic until you can rule out anything else. All of the hematocrit punya effect yang I've tengok semua ectopic bleed. Lastly, assessment of cardiac function. So eyeballing is a typical way to do assessment of cardiac function, but there's a easy way to macam quantify as sufficiently whether or not the contractility is good or bad with a numerical support value. It's called E-point sector separation. It doesn't take a long time, so you can use this to macam categorize further whether or not your patient has good contractility ataupun moderate contractility ataupun poor contractility, and it's much more robust than eyeballing. And then this is regional wall motion abnormality, and you typically see in ischemic punya causes of heart failure. So
Cepat dah nak habis. Masa.
So you have to correlate this with your ECG apa semua. Next, your pericardial effusion. So the amount of patient is in cardiac component will be dependent upon clinical assessment and your ultrasonography assessment of whether or not there is atrial ataupun ventricular collapse. This is RV strain. So as you can see here, there is the septum is being pushed to the left ventricle side, which is abnormal. The left ventricle is the bigger punya heart, it's the bigger punya ventricle. It's supposed to push the septum towards the right, but in here it's the opposite. So this is typically acute ataupun chronic and decompensated pulmonary hypertension. This is cardiac LV thrombus. So LV thrombus can cause shock in a myriad of ways. The typical one is kalau dia besar sangat, it occupies so much space that there's no stroke volume. Ataupun sometimes you see this, ada clot fly off, pergi ke mesentery ke, pergi ke brain ke apa, and they develop benda-benda macam bacterial infection, gut perfusion leading to mesentery ischemia. So this is the first the prototypical approach to undifferentiated patient with shock using ultrasound without HIMAP. So it incorporates all the things that you see before, and you have to make a reasonable deduction about why the patient is in shock. This is for the most part adequate, but in certain patients, macam you look at the control expression, it may not explain kenapa patient ada shock. Okay, so before we talk about VTI, before we talk about VTI, we have to talk about this. How many of you know what this is?
CVP.
Swan gas.
Apa dia?
Swan gas.
Apa dia?
Swan gas catheter.
Swan gas catheter.
So-
Mana letak dekat right atrium.
Yeah. So similar to how
Zaman dulu sebelum ada ultrasound, sebelum kita pakai ultrasound, pakai swan gas tak dekat pulmonary artery, right atrium. Insert macam insert CBL.
way more difficult. Like you have to place it dalam the pulmonary artery.
Pulmonary.
Similar to how passive leg resistance is the gold standard, most of the assessment of ultrasound for hemodynamics uses the reading from a Swan gas catheter as a gold standard. You don't really see this outside of hospital yang ada cardiothoracic punya unit, because this is what cardiothoracic likes to use to monitor the patient. You can take it easily chart, you can ada real time punya monitor apa semua, you can measure core temperature, you can bagi central punya medication. It's quite good.
And they will diminish shock.
It's very good. The problem is, again, with privileging, this is not something yang bodoh-bodoh punya procedure, you can cause quite a lot of harm kalau buat yang ni. So the actual reason for this presentation, the LV only velocity time integral. So the VTI is a surrogate for stroke volume. It allows you to complete that two equation and make an informed decision on whether or not the patient can handle volume, and it can also help you to diagnose shock further. So in order to get a good measurement, you have to achieve a few technical punya criteria. You have to do a 4-chamber view, then you find outwards until you see the 5th chamber, which is your aorta or your upper tract. You need to try to ensure the flow, the pulse is
Macam mana tengok, okay? So basically kat 4-chamber view ni, kat sini kan. Okay, so yang ni dia punya right RV, RA, AA, LV. Itu bila kan kat sini kan dia ada LVOT kan. So kalau you buat this one is 4-chamber view lah, you buka sikit kan. So dia ada LVOT. Dia aktif kat sini. Okay, lepas tu you kira seluruhnya kat BTI ni kira dekat dalam Doppler lah kan. Doppler, pathway Doppler. So you letak macam tu. So dia akan jadi berapa normal?
Usually the normal is 20 centimeter plus or minus 3 centimeter. So you classify into high ataupun low LVOT VTI. So there's a few assumptions that we make to measure LVOT VTI. As a surrogate of stroke.
Sebenarnya penting tahu juga sebenarnya untuk you guys tahu VTI ni, sebab dia dalam management of shock juga sebenarnya. Okay, sebab you nak tahu patient ni nak kena start apa, nak bagi fluids ke, nak start vasopressor ke, nak start adrenaline ke, nak start noradrenaline ke, nak start dobutamine ke. It depends, sebab kalau ada certain condition you tak boleh bagi 20 vitamin dan condition dia tak boleh bagi adrenaline. Okay.
So there's this function in calculus called integral, and it allows you to assume that the area here represented by the cylinder is representative of stroke volume. So you can easily measure the surface area of this circle.
LVOT.
Yeah, LVOT. The variable that you don't know right now is just the length. Different people in different states have different length of that cylinder, and if you can find the length of that cylinder, you can assume the stroke volume of that patient. Okay, so how do you find the length of the cylinder? You apply the Pascal Doppler, macam Fiza cakap tadi, and you will get this graph. So the area under the curve is going to get put into an equation that yields an integral that gives you a value in terms of centimeters, and that centimeter allows you to care about the stroke volume. Okay. So now you can fill out this equation and complete the rest of
Boleh
the
tak ingat equation tu? Okay, VO, hemoglobin, SO2, lepas tu PaO2 PaO2 dari 0.03. Okay. Basically, tak ingat pun tak apa, tapi you have to have some idea apa dalam tu. Okay.
So again, the normal value for LVOT VTI is 20 or minus 3. So you then can classify the patient as having low or high LVOT VTI. So what's the cause of high LVOT VTI? Typically, it's distributed shock. You have a low afterload, and this causes a faster flow from the left ventricle into the systemic circulation. However, you also see a aortic regurgitation because there is backflow of blood. This backflow of blood acts as a preload, which again stimulates contraction. But the ejection fraction, ataupun the blood being pumped, are not all reaching your systemic circulation. So it's a pseudo high VTI. It doesn't really work as a perfusion.
So yang macam patient kita yang tu 60 VTI dia.
Yang tu
kita skip bagi tahu dia orang macam mana.
If I remember correctly, he had an infection primarily.
Patient 37 years old, dia ada lain diabetic hypertension, renal fail, CKD ya. Kita dengan sepsis lah, basically integrated. Secondary itu pneumonia. BP dia low, kan? Heart, good heart kan, conductivity cantik je. Tapi VTI dia apa? 60-70.
So the source infection went to the lung. So the suspicion is that patient has developed that systolic anterior motion abnormality because of the high cardiac output, high output cardiac failure.
Sampai double inotrope kan? Sepatutnya tak payah pun. Sebab initially, sebab tu kalau kes macam tu sebenarnya kena scan dulu lah. Cari VTI. Lepas dia tengok, oh VTI dia tak low. Sebenarnya kalau VTI dia low, you boleh bagi fluids. Senang. Okay? Tapi sekarang ni VTI dia tinggi. So you tak nak bagi fluids ke ataupun you nak start inotrope, you nak start vasopressor. Bukan inotrope dah. Okay? So you tengok dia punya, bukan inotrope dah. You tengok vasopressor ke, you nak tengok inotrope. Nak bagi inotrope ke atau vasopressor ataupun you nak bagi fluids. So you buat yang LVOT VTI tu lah. LVOTO yang tengok dia punya ada levoto tak. So kalau yang kes macam ni, possible dia ada levoto. Sebab tu bila dia ada LVOT obstruction, patient tu dia initially dia bagi high dose NORAD. High dose NORAD, lepas tu still low. Lagi worsening dia punya acidosis tu. Okay, so tambah lagi, apa benda tak? Adrenaline. Itu increase dia punya inotropic. Lagi worsening, betul triple inotrope. Lepas tu last kali, bila kita tengok sebenarnya patient tu dia levoto. So we just sepatutnya kena reduce. Pelik tak? So BP dia semakin low tapi you reduce dia punya inotrope. Tu sebab tu dia mesti kontradik. Kalau orang yang tak tahu dia rasa kontradik, sepatutnya kena tambah lah. BP dia high, BP dia low dah, you nak reduce kenapa? Okay, sebab tu you kena tahu patient tu dia ada LVOTO. So you tak boleh bagi inotropic. Okay, so you tak boleh bagi, kalau patient tu dia very high VTI patient tu kan. So maksud dia punya very vasopressic sebenarnya. Okay, patient tu very sepsis. This very distributive shock, vasoplagic. Waktu tu tak ada lagi yang apa? Sinus tu tak ada lagi waktu tu. Dia sinus bila dah bagi apa nama, bila dah macam trigger anoshock dah. Okay, so basically day end punya tu. Okay, so bila case macam tu, saya lihat dekat ICU lah, dekat ICU dia orang reducekan benda tu, dia orang dah topakkan vasopressin. Okay, terus boleh reducekan dia punya anoshock, kurangkan dia punya anoshock. Okay, sama juga lah patient tu kat ICU. Tapi improve lah, lepas saya bagi dia vasopressin, cut adrenaline, remove the adrenaline, reducekan noradrenaline, and so eventually you remove off adrenaline, so vasopressin sahaja, dan sekali patient tu extubate. Okay, so dekat sini kita dah tengok, oh patient ni memang dah teruk gila lah ni, dah tiba ada throat semua, dah tak boleh nak buat apa dah sebenarnya, sebab kita tak tahu apa sebenarnya what is happening to the patient. Kita rasa macam oh dah tak ada harapan, sebenarnya ada harapan sebenarnya, sebab kita tak manage properly kan. So that is very important for you to know this. Okay,
I think even if you tak buat pun, kalau you ada patient sepsis ke distributed shock kan, the heart rate dah 130 BP normal, your second agent shouldn't be something yang ada beta agonist effect. Just choose vasopressin. You might think that
I perasan you all jarang tahu guna vasopressin.
Sebabnya kat sini kalau pas start vasopressin tu dia kena admit ICU je, tak ada yang general ward.
yeah.
General ward tak ada vasopressin.
Tak apa.
So kita ada tengok
So why? Sebab patient ni, okay, because kalau, okay, so patient ni, you tahu tak, vasopressin ni, especially patient yang memang very vasoplagic, yang vasodilate semua, sepsis lah, basically sepsis. Okay, the best is vasopressin. Satu, vasopressin tu dia tak affect dia punya heart pun, langsung dia tak affect heart. Okay, so kalau you tengok scan dia heart dia cantik semua, kenapa nak kasih heart dia? Ada kalau macam patient tu dia ada heart failure, okay, poor conductivity, then you boleh lah bagi norad ke, adrenaline ke, whatsoever yang boleh ada nootropic effect. So but the problem is heart dia cantik, especially young patient kan, heart dia cantik. So vasopressin satu dia tak kasih heart langsung, and then satu lagi dia increase GFR. Okay, so dia punya renal function okay, good urine output. Perasan tak, you bagi triple air tu terus tiba-tiba renal shut down, tiba-tiba tak ada urine output. Sebelum intubate ada je urine output, lepas intubate tak ada urine output. Bila you bagi norad apa semua kan, macam tu lah sebenarnya, tak ada urine output. Sebelum tu ada je urine output. Okay, so
patient ni stranded anaknya, so kalau you start a proper punya anesthesia, there's a possibility yang dia be reverse.
patient tu reverse tapi lambat lah.
So for high LVOT BPI, you might think it's an easy macam easy tak differentiate between distributed shock and aortic regurgitation, but it's not really true because the murmur for aortic regurgitation is the diastolic murmur, and I've long had this belief that diastolic murmur is just an invention to torture medical students.
Apa diastolic murmur? Apa lah ada lah.
So really common.
It's not common. Tapi sebab you tak dengar sangat. Senangnya you nak dengar murmur, sekarang dah ada ultrasound. Buat je lah ada bunyi. Kan, kat echo kan.
So last part of this presentation is the selection of vasoactive agents imaging shock. So this is I think the most comprehensive image I provide on the internet on what type of
Mana vasopressin?
because there's a CV punya apa NS tak ada, they have
Fenilefrin tu lebih kurang vasopressin jugalah. Okay.
So basically, if your patient dah ada high cardiac output, heart rate is good, cardiac output is good, systemic vascular resistance is low, you should pick something yang more specific towards your improving your vascular tone without affecting your cardiac output any further. Ingat balik that gambar tadi, you increase the inotropy. It's not just yang you might introduce Levanto, you also increase the metabolic profile of the heart, and that's not good in long run. Okay. Another thing is for ACS. I think for ACS, you have to be happy with a bit lower punya BP. The afterload is actually good for the heart, man. So kalau nak kata you have to put strict 65 mm mercury as your target. Tapi in doing so, you start low dose adrenaline yang jump up jadi 75-85 is actually not that good for the patient. I think kalau perfusion of the vital organ is okay, it's acceptable. As long as the urine output is good, most of the time it's going to be fine.
Contohnya, patient tu MVP 60. Tapi CCTVR dia semua okey je. BP dia memang low. Okay, hari dia a little bit tachycardia. Okay, so boleh je dia nak bagi fluid dulu tanpa kata ada masalah. Tapi jangan start and put patient macam tu.
And another thing that you need to remember when you give enteral ataupun parenteral punya medication, it doesn't just go to the systemic circuit, it also goes to the pulmonary circuit. Remember again about the metabolic punya control and the endocrinological and immunological punya adjustment that you need to consider in your patient, especially those yang stranded. And last, I'm going to touch about refractory vasopinta. This is a increasingly identified problem that we have in semua tempat lah. The initial punya reports came from cardiothoracic punya surgery. Basically, you have this on-arm bypass. You develop this very weird
Dia tak tachycardia lah.
yeah, dia tak tachycardia, distributive, pure distributive shock. Dia orang bagi Norep, tak improve. Bagi vasopressin pun, most of the time tak improve. So these patients, I don't know what's the mechanism, but they tried methylene blue and hydroxycobalamin as a potential way to reduce.
Cobalamin tu vitamin? Vitamin B. B-complex.
So that managed to attenuate
Betul. Okay lah.
reduce the nitric oxide production and improve dia punya patients punya recovery both in terms of mortality and shock pressure free days. So I think I've encountered this few times, but macam tak boleh nak interview. Okay. Inhale pump due to type your problem. So if you have the acute pulmonary hypertension, your fluid not optimized, patient is still macam in extremis. You don't want to intubate the patient because if you intubate a patient with RV failure, that's when they deteriorate the fastest. So you can consider inhaled pulmonary vasodilators. This is something that you should do under supervision by a specialist.
Amboi. Okay. Continue.
So the only agent that we have is GTN and then sada nitric oxide. So basically it's the same vasodilator, but now it's targeted towards only the lung without any spillover effect, your system assassination. It's quite effective. The problem is the effect there is low. It takes 15 minutes to administer. Dia cuma last 30 minutes, so you only get 15 minutes of macam this chance untuk tengok sama the patient akan revert back to compensation ke tak. So sometimes it works, sometimes it doesn't work. But when push comes to shove, you can consider this as a modality of therapy. So that's it. Any question?
Banyak, faham tak? So basically management of shock, you tahulah, you kena tahu apa dia punya classification of shock. Okay, so dia ada 5, cardiogenic, obstructive, distributive, hypovolemic, and last sekali distributive shock. Okay, so and patient datang dengan evidence of shock, clinical evidence of shock. So you basically dalam shock you kena tahu apa dia evidence of shock, clinical evidence. Clinical evidence maksudnya from head to toe lah. So reduce perfusion to the brain, patient agitated, delirium. Reduce perfusion to the heart, patient chest pain, ongoing chest pain. Reduce perfusion to the gut, bowel, patient akan datang dengan abdominal pain, vomiting, dia vomit, not necessarily patient tu AGE sebenarnya. Patient tu sebenarnya dia vomit because dia got hypoperfusion, got ischemia. Got ischemia, so secondary tu hypoperfusion. Okay, ataupun dia datang dengan you reduce uric output, reduce hypoperfusion, motor scheme semua. So basically that clinical of signs of shock, apart from the CCTVR. So you tengok patient and then you touch patient. Then cari evidence of shock. Bila dah cari evidence of shock, okay, and then you tengok pula what kind of shock yang easily treatable. Easily treatable, hypovolemic dengan obstructive shock. Yang paling senang lah backside kan. So lepas tu baru you move to cardiogenic, distributive. Okay, so kalau distributive tu, okay, so maksudnya patient sepsis lah. Okay, patient sepsis dia datang dengan fever ataupun tutup white dia raise, and evidence of pneumonia, ada infection relative whatsoever lah. Ada source of infection. Okay. it can be overlap. Sepsis ni is not as simple as sepsis. Sebab dia dalam patient sepsis, dia boleh dapat hypovolemia, dia boleh dapat cardiogenic, and dia boleh dapat dissociative. 4 in 1. Okay. So sebab tu, bila patient sepsis tu, you kena tahu ada benda yang boleh you reverse tak? Macam contohnya dalam sepsis, hypovolemia, okay, you check dia hypovolemia, cardio-contractility, sometimes septic induced contractility, myocardial depression. Okay, septic cardiomyopathy ataupun dengue myocarditis. Okay, boleh dapat poor contractility. Okay, so you tengok, is it contractility punya problem, dia ada co-shock overlapping shock, cardiogenic. Okay, so lepas tu, kalau macam contohnya patient BP dia low gila lah, memang sampai unrecordable, patient sepsis semua tu. Okay, so you tengok macam mana you nak manage patient macam tu. Sebab you sekarang ni, the paling urgent is you nak restore dia punya perfusion kan. So of course you bagi fluids. Okay, tapi in the meantime you bagi fluid, you kena bagi, kalau patient tu septic shock, so you bagi vasopressor. Okay, together vasopressor and shock, because vasopressor and also fluids resuscitation. Okay, so because you nak dia punya increase dia punya perfusion. Cepat-cepat sikit improve dia punya perfusion. Okay, so kalau let's say kalau patient tu poor contractility, senang je, tak payah tunggu vasopressin, you ambil je Norep ataupun adrenaline. Okay, you dilute, lepas tu you push, sementara you push bagi drip. Okay, any questions? Senang tak benda ni? Okay lah, it's not that easy sebenarnya, cakap ni easy, tapi actually benda tu okay. So benda you kena, especially kalau you dapat case yang macam very macam difficult, yang macam patient tu lah. Okay, so contact ni, patient tu dia apa, selain very vasoplegic, satu lagi dia high output. Okay, maksud macam sampai medical pun macam pelik lah, bila buka je dia punya, bila cucuk kan nak buat femoral catheter ke, dia punya vein tu macam mencurah-curah macam tu. Dia kata peliknya patient ni fluid dah macam cukup semua, tapi macam dia punya vein tu macam artery punya penting, faham tak? So maksud dia macam very, satu banyak, satu lagi dia punya kontak itu sebenarnya bagus lah kan, tapi kenapa pelik, dia macam medical macam pelik, tapi kenapa sampai double anatrope? Sebab we don't see what is happening, so what the mind doesn't know, okay, the eyes will not see. Sebenarnya sebab tu lah dia ada very vasoplegic, and also patient tu dia ada LVOTO foto. So basically dia bagi noradrenaline, poisoning dia punya levoto, and then dia punya vasoplegic tu you tak kata dia punya vasoplegic tu betul-betul. So tak ada yang pelik sebenarnya kan. So kalau kes macam tu, okay, panggil lah, kalau you tak sure nak manage semua, you panggil je lah EP. Okay, you panggil EP. So panggil EP, so dia okay, patient ni tak tele lah, patient ni in shock, tapi kenapa dia punya apa nama vein bila buka mencurah-curah kan. So macam pelik, sepatutnya BP dia high lah kan. So you kena tahu kenapa jadi macam tu. Macam ni lah, you bagi sebenarnya tahu lah kenapa patient bagi tu. Satu, you bagi fluid banyak. Okay, lepas tu vaso dah dilate, contractility dah cantik, okay, fluid banyak, so mencurah-curah lah dia punya vein tu. So basically patient tu dia ada overload. Okay, overload, lepas tu sebab you bagi fluid lah, you bagi fluid banyak. Okay, causing overload. And then satu lagi, patient tu dia ada very vasoplegic, severely vasodilatation, and also LVOTO. Okay, 3 benda. And it's a vicious cycle. Sebaik dia masuk ICU. Okay, masuk ICU, lepas tu dia bagi tukar lah dia punya tu, patient survive lah, mudah je. Okay, any questions? Boleh ya, finish? InsyaAllah. Boleh. Sebab tu ada CME ni sebab itulah kita nak Kita tak nak do no more harm to the patient. Okay, boleh siapa nama? Sarah. Sarah kat mana sekarang? I mean dekat jaga
Jadi lagi.
Ha? Tegi kat mana sekarang? Yellow. Okay, macam ni. Sebelum ni kat mana?
Kampung sama.
Buat mana? ED. Oh, okey lah tu.
Dia tadi sebab dia tak biasa dengan komputer.
Dekat ED Sarawak. Dah berapa lama dah?